Hello and welcome. Moss Adams is pleased that you joined us for today's session, Medicare and Medicaid Value-Based Payment Models Update. And now I'm going to play our housekeeping video.
Welcome, and thanks for joining. We're pleased to present our continuing professional education webcast series. Before we begin, please keep the following in mind. You can customize how you view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can adjust window size and placement or enter full screen mode using the controls at the top right of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons that relate to a different aspect of our session. You can download a PDF of today's slides from the Slide Deck and Handouts widget. You can ask questions by typing in the Q&A window and clicking Submit. We'll do our best to answer all questions or follow up via email. If you experience technical difficulty, refresh your browser by hitting the F5 key. Today's session offers 1 CPE credit. To receive credit, you must meet the National Association of State Boards of Accountancy requirements. You must attend at least 50 minutes of the session and respond to at least 75% of polling questions. To participate in the polls, please check the button next to your answer within the slide window and click Submit. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget and download your CPE certificate. Don't worry if you can't download your CPE certificate today. We'll email you a copy in 2 weeks. If attending this webcast in a group, you must complete our group CPE attendance sheet, available in our Slide Deck and Handouts widget to receive credit. Please have all group members sign it and send only 1 sheet per group. CPE credit can only be awarded to participants registered as themselves and isn't available for participants who view the on-demand version. This presentation is not legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
All right, and we have 3 presenters with us today, all from Moss Adams. We have Georgia Green, Senior Manager, Stephen Hartley, Manager, and Pat Oungpasuk, Manager. Their bios and contact information are located in your webcast console. And now I would like to turn the floor over to Georgia to get us started.
Thank you so much, Amy. So here's our agenda for today. We're going to be talking about alternative payment models and value-based care in general. And then we will dig into the meat of this, which is about all of the new and emerging models that are coming out this year, things you might have heard of, things you might have applied for. We're going to summarize each of those. And then at the end, we'll talk about some strategic considerations for organizations that are participating in these models or similar value-based care models. Our slides are very information dense. They're meant to be a resource for you. So we may not talk about every single bullet point on the slides today because we're moving quickly, but I want you to know you'll get these slides via email after today's webcast. And I hope that they'll serve as a good reference material for you going forward. Also, you can put questions in the Q&A box. And this is not one of those webcasts where everyone will see your questions. So it is a private box. It'll only be seen by us here at Moss Adams. And we'll be happy to try to answer your question either live on the call today or we'll follow up with you via email. So please feel free, put your questions in there. I know there's a lot of folks on the line who know us. So if you just want to say hi, feel free to do that too. If you want to tell us about how your eclipse went yesterday, you can do that too. The chat box is all yours. So we'd love to hear from you. So let's get into it. We're going to talk about value-based care. So I know this sounds very rudimentary, but there is a very simple value equation down there on the bottom corner of the slide. You can see value is quality over cost. So when we're talking about value, we're really talking about models that increase quality without increasing cost or reduce cost without reducing quality. So if it can do one of those two things, that is a value-based model. If it can do both of them, even better. And what you'll see with all of these models is that they include both cost and quality incentives. So there's quality measures you report on, there's cost and quality outcomes that are being rewarded. It used to be called the three-part aim, or some people say the triple aim, to improve clinical quality, reduce the total cost of care, and promote population health. That's keeping everybody healthy proactively. That has expanded. Like anything, there's always scope creep, and it then became kind of the quadruple aim, where we also, of course, are very interested in improving provider experience and reducing burnout. And allowing providers to deliver the type of care that they, want to. And then in recent years, it's also expanded. I don't think anyone's calling it the quintuple aim, but there's obviously a lot of emphasis on equity and care access. And CMS, recently reiterated their priorities are growth, alignment, and equity. So you're going to see in all of the models today, whether or not we talk about it in each one, but there is, if it's a new model, there's an aspect of it where they are measuring health equity, or they're having you measure health-related social needs, HRSNs. That's really a running theme of all these models. I think the really important thing to understand is that in 2021, CMS established a goal to have 100% of original Medicare, that's traditional fee-for-service Medicare patients, in a value-based care arrangement, and the vast majority of Medicaid beneficiaries as well. So they've really been working on this since the passage of the Affordable Care Act in 2010, Obamacare. It created this innovation center. And the way they are moving folks into these value-based arrangements is through testing different models. So they're saying, we don't know what's the perfect solution here, but we're going to test out different types of incentives and see what works. And that's what they've been doing, is rolling out these models, offering incentive payments, offering payment enhancements, and trying to get folks to kind of engage in this process before it becomes mandatory, and not having to make it mandatory off the bat. So it's all about bringing a population of patients close to you and not waiting for them to walk in the door, but thinking about your active outreach to those patients. Care delivery redesign, which it doesn't have to be one thing. It can look different at every organization, but these are just some common elements that you might see: care coordinators, care team approach, really leaning into data and data analytics to manage your patient population. It also involves thinking outside of the four walls of your clinic or your health system even, and thinking about the patient's total cost of care. What's their experience everywhere they go, whether that's in your facilities or somewhere else. I have talked to a lot of CFOs about these programs, and no offense to the CFOs, but the very common question is always just, why would we do this? It seems counterintuitive, to say the least, to reduce utilization, or no margin, no mission, right? You need to make money to continue being able to serve your patients. And so it can be a little bit of a mental hurdle to understand how to do this effectively without hurting your own organization, hurting yourself while doing it. Then a few years later, it's really rewarding to talk to the same person and have them say, we've made a total change to how we deliver care, and we could never go back to that old way of doing it. So I do think it's possible for any organization to make that transition. And I do think everybody is sort of on a spectrum of, are you at the beginning or are you very advanced in this? But you're somewhere along that spectrum. And CMS wants to push you more toward the advanced end. So there are financial incentives for doing this. There are, certain carrots, certain sticks that are going to motivate folks to be in these value-based programs. And the notion here is that, kind of the earlier you get in, the bigger the carrots are. And maybe over time, those carrots kind of get a little smaller and the sticks get a little bigger until it's, a mandatory program that everyone has to do. Again, they do want 100% of original fee-for-service Medicare patients to be managed under one of these kind of models or relationships by 2030. And that's not that long ago. We're, halfway between 2020 and 2030 now. So just think how soon that will be. So carrots in these models, predictable and prospective payments, giving providers more flexibility in how they deliver care, giving financial rewards to organizations that can deliver high quality and can contain the total cost of care. There's payment enhancements within each program. And there's also the MIPS program. If you're not familiar with that, we probably could have a whole another webinar on that one, but it's an annual quality reporting process to Medicare, and your performance on it adjusts your Part B payments 2 years later. So your 2023 MIPS score would then impact your 2025 payments, for example. So when you're in these models, you're going to perform better or have easier, let's say, more simplified MIPS requirements, and perform better and get that higher boost on your payments. There's also the public reporting of your quality scores on Care Compare. It used to be Physician Compare or Hospital Compare. So just knowing that there's good public information about your organization when consumers are out there comparing you to your competitors. Also, you can gain some efficiency from having multi-payer alignment. I know that, again, was one of CMS's goals with this, is to increase alignment. So that's something you'll really see trending in all of these new models, is they'd want it to not just be that you're doing one thing for Medicare and a different thing for Medicaid and a different thing for all your commercial payers, but that they're really all kind of aligned with each other with the same incentives and the same quality measures to make it simpler and easier for you to treat patients. Of course, there's sort of this fear of models becoming mandatory. We're not quite there yet, although there are some mandatory models, kind of one-off models. But this is about preparing yourself and getting the training wheels on so that you're just hitting the ground running when things do transition to more mandatory nature. So I'm not going to talk about all these different benefits of being in these models, but some I haven't mentioned yet. I just want to highlight that you do get access to more data. So if you are a little bit of a data wonk, and I would argue probably everyone in healthcare is or should be, it's exciting to get complete claims data about your patients so you can understand those patterns of care delivery, where they're going. A lot of times people don't really understand, and how could you understand the leakage out of your network or out of your area unless you have that complete claims data. So it's pretty cool. There's legal waivers in some models. Most of these models you can withdraw from if they are voluntary, so you can try things, and if it really isn't working, it's not a permanent thing. It's not a tattoo, so you can get back out of it. Don't worry. So this slide is really about the things that we've seen with our actual clients, them doing and them needing, maybe stumbling blocks along the way, and some of the challenges you might face on this journey. And I would say getting started is really one of the biggest ones. It is a really big hurdle when folks first hear about these models and they say, oh my gosh, we're going to need to do the application. We're going to need to set up legal structures. We're going to need staffing and operational plans and governance and compliance and contracts and all these things that feel really big to put together can just stop people dead in their tracks and say, but yeah, we're just not going to do this until we have to. But I want to encourage you all to try to overcome that hurdle, because there are so many resources out there to help you. We are one of them, but we can also point you to other resources to just help you get past that first point and get an application in and really start to get your team educated about what it is and do small incremental things. You don't have to do all of these things on day one, and they don't all have to be perfect. It can really be a step-by-step, take one bite of the elephant at a time kind of thing until you're fully rolling. But I do think about things in these buckets that there are, sort of patient-facing processes that are very important in value-based care. Really great area to, kind of implement Lean or Six Sigma, kind of thinking about how do we standardize this? How are we going to get patients doing chronic care management that have chronic illnesses, or transitioning out of the emergency department to the best setting for them? Our internal processes, how are we going to define our team and our processes? What are we going to do in terms of a data warehouse and reporting? Very important, not only for leadership, but also having physician and provider facing reports that are actionable for them, kind of checklists and care gap lists, that kind of thing. And then as you get kind of further down across the spectrum, let's say, more advanced, you're really thinking about, managing your post-acute care network, length of stay, preventing admissions and readmissions, really having that network of the high value specialists that, deliver high quality care and manage their patients well. So I have a couple slides here that just list out a lot of models. As I mentioned, this Innovation Center started in 2010 and has been rolling out models nearly every year. There was a bit of a pause during COVID times, understandably, but we are not going to be talking in depth about any of these models today. I just kind of wanted to have this here as a resource, and these might be familiar to you. These were our voluntary models that are operational right now. And there also are some mandatory models that are operational now, or kind of wrapping up. So you may have heard of some of these models. These are all examples of value-based care programs under the Innovation Center. So we're going to pause here and have our first polling question.
All right, thank you, Georgia. So the first polling question is, which of the following is not a potential benefit of participating in an alternative payment model? And the polling questions are located right on the slides that we're presenting. So if you can't see it, you may need to hit the F5 key to refresh your console. And we do have quite a bit of content to get through today, so we're going to try and move through these polls pretty quickly. You'll just select the button next to the answer you choose and then make sure to hit that submit button.
Thanks, and we're starting to see a few questions come in the chat box. I definitely encourage everyone, if you have questions, feel free to put them in there and we'll do our best to follow up with you.
All right, we'll do 5 more seconds here. And here are the results.
Okay, I think the majority of you got it correct. So the right answer that is not a potential benefit of these models is answer C, no requirement to report clinical quality measures. These models do still have you reporting on quality measures. So that is something they want to make sure you are maintaining or improving quality while reducing cost. Okay, so our next section, we're going to talk a few slides about the Medicare Shared Savings Program, and we're spending a bit of time here because this is an ongoing program. It's been around for over a decade. It is the largest program in the country. There's currently 480 Medicare ACOs, as they're called, accountable care organizations, with 10.8 million Medicare beneficiaries. And 2022, which is the last year we have this data available, 63% of ACOs earned a shared savings payment. So you can see this nice little map shows where those Medicare ACO lives are located. So this is a transitional program. It's not necessarily meant to last forever. It's hard to earn shared savings forever, but it is about transitioning from that fee-for-service notion, which is just about volume, toward fee for value, where providers are earning a reward for reducing the total cost of care and delivering high quality care. So it does require formation of an ACO, the Accountable Care Organization. And I have my little clip art of an umbrella here because I think of it as that umbrella organization. And underneath it are the participants, which are tax ID numbers that are enrolled in Medicare. So it can have one participant under it. It can have lots of participants under it all together. Patients then become attributed to those providers that they receive the plurality of care through, under the umbrella with those participants. And the group as a whole becomes accountable for the total cost and quality of those attributed patients' care, whether or not that care happened at your facilities or outside of the umbrella. So you're thinking about everywhere the patient's going, everything that Medicare is paying for that patient. What's nice is in level A and B, it used to be called track 1, but they kind of changed the terminology on this in 2019. It's really a bonus only program. So that means you can earn shared savings. And there's no penalty to you if costs increase during the program. The way that it works is about comparing cost in a benchmark period versus the performance year and saying, did costs go up or down? And this is all relative to the normal growth in costs that are happening nationally and regionally. So it's really how well are you controlling costs compared to everyone else in the country. One nice thing about these programs is that nothing about your billing or reimbursement process changes. So you keep dropping claims to your MAC and you keep getting paid. If you're a little bit more of a visual person, here's a nice visual representation of that. So you can see in the benchmark 3-year period before the program starts, these are all really round numbers. The average cost for your Medicare patients was $10,000 per patient. But then you implement your ACO, you've got care coordination, you're doing annual wellness visits, you're doing care transition management out of the hospital, and you manage to bring the average cost per patient down to $9,500. So you have generated $500 of savings. If you weren't in the program, Medicare would take that $500 and stick it in their pocket and, you'd go on your merry way. But by being in this program, you actually get to share in the savings with them. So you keep 40%, they keep 60%. So you get $200 per patient back at the end of the year. So that's the incentive. And then after your first year in the program, this is modified by your quality score. So let's say you got an 85% quality score. Instead of getting $200, you'd get $170 per patient. And then you, the ACO, share that out to the providers in the ACO to reward and incentivize them. I'm not going to read all of this, but there are certain things you need to comply with this program, but it is quite flexible. You do have to have a total of 5,000 Medicare fee-for-service lives. So that's why you'll see a lot of these aggregator ACOs out there, the Caravan Healths and the Alidades of the world that are bringing together smaller practices, smaller health systems that can't meet that threshold by themselves and putting them together in groups. You would need to have quality reporting and improvement, evidence-based medicine, care coordination, patient engagement, and data warehouse capabilities. But again, it's very flexible about how you implement those requirements. So that's about the Medicare Shared Savings Program. This year, there is a brand new program. It was just announced in the last month or so. And my colleague Stephen is going to share with us about ACO Primary Care Flex.
Thanks, Georgia. The ACO Primary Care Flex model, PC Flex model, is an interesting new program from CMS. It's designed to increase access to high quality primary care for Medicare patients. This is a special opportunity as the PC Flex model is a 5-year voluntary model operating within the Shared Savings Program. It'll begin on January 1st of next year. To participate, participants must first apply to the shared savings program and then to the PC Flex model within it. The model aims to increase the number of low revenue ACOs in shared savings, as these programs have historically performed better in shared savings, demonstrating more savings and higher improvements in quality and efficiency of care. Shifting away from the fee-for-service payments, the program will offer an initial advanced shared savings payment of $250,000, which will help cover the costs associated with forming an ACO and the administrative costs related to model activities. The model will also implement prospective primary care payments, which will be monthly payments based on the county's average primary care spending, in addition to payment enhancements intended to provide additional resources to ACOs. CMS anticipates that for most participants, the PPCP will actually increase primary care funding relative to the ACO's historical expenditures. With more information being released this spring, the initial application will be due June 17th of this year, again, after you apply to shared savings, and the model will operate between 2025 and 2029. And now Georgia will explain the timeline for both models.
Thank you so much, Stephen. So again, this is upfront funding, $250K per ACO, and a new prospective primary care payment for those ACO participants, the provider practices within the ACO, that's replacing their fee-for-service reimbursement. So pretty interesting, and the request for applications is forthcoming. So this is our timeline. As Stephen mentioned, June 17th is the deadline to apply for both MSSP and this ACO PC Flex model. They're kind of a simultaneous application, really just kind of applying for the MSSP or renewing as a new in a new contract period if you're already in that program, and then just checking the box that you'd like to be considered for the PC Flex model. The MSSP application process is an annual recurring process. It's really an ongoing program that occurs throughout the summer and into the fall. It has some RFIs, or requests for information, where you can kind of dance and go back and forth with CMS a little bit, make some clarifications. But it concludes with doing an e-signature process in early December of each year, and then the program starts on January 1st of each year. So this is a very, kind of consistent process. If you're in an ACO, this is the time when you can get out of it if you want to get out or change ACOs, or if you have an ACO and you want to add participants, this is the time that you do it for the upcoming year. I also briefly want to mention the ACO REACH program, brief because it's not open for new ACOs to apply to it, although it also has an annual process similar to MSSP, where certain participants in REACH ACOs could be added or dropped. But this is what I would call, MSSP on steroids. It's a similar type of program where you're managing the total cost of care. But in this program, CMS is offering some upfront payments, kind of a cash flow mechanism, where they give you primary care capitation payments. And there's a couple of different options here, professional and global, with a 50% and 100% financial risk, respectively. So it's a bit of a higher risk, higher reward program, and slightly different in having those capitation payments. So we'll pause here for our second polling question.
All right, thank you, Georgia. So the second question is, which statement about the Medicare Shared Savings Program is true? And then as you respond to that, just a reminder, if you would like to receive CPE credit for today's webcast, you will need to respond to at least 3 of the 4 polling questions. And then again, please click the button next to the answer you choose and make sure to hit the submit button.
There is an interesting question in the chat that says, payers like Optum have been in trouble due to their HCC coding and risk scoring practices. are patient outcomes really improving, or has this become a risk scoring game? That is such a thoughtful question. I think that, yes, there is an aspect, especially in Medicare Advantage, of HCC upcoding being kind of a big part of the success of the Advantage plan. And there being some gaming going on. Game's probably the right word there. But that said, I think really there probably are more organizations out there that are really undercoding or not coding their patients correctly and appropriately. Certainly an important value-based care strategy is getting your HCC coding correct and at the highest level of specificity and acuity that is appropriate. Definitely. In terms of the quality measures, those really aren't about risk scoring. They are clinical quality measures. Things like, do the patients have their mammograms done, timely? Are they up to date on their mammogram or their colorectal cancer screening? Did they get their flu shots? Did they get a fall risk screening? These kinds of clinical activities. So it really doesn't have anything to do with HCC coding. You can just, it's making an incentive and then, showing your performance on how you're providing care to patients. Okay, so let's see, the majority answer, ACOs have flexibility in how they meet program requirements. I'm glad that that's still, that we're getting the majority there. Would like to emphasize that it's not a one size fits all kind of program. You can design these to work for you. Okay, I'm going to hand it back to Stephen to share with us about a new model called Making Care Primary.
Thanks. The Making Care Primary program, or MCP, is a model that was announced last year and it begins July of this year. Applications were due last November. This is a 10.5-year model, which includes the 8 states listed here. The program is a multi-payer model, with CMS announcing their program requirements already and will partner with each state's Medicaid agency, although most state-specific programs have yet to be announced at the Medicaid level. Eligible participants needed a minimum of 125 attributed Medicare lives. And the program includes a health equity plan and required reporting on care delivery, socio-demographic data, and quality measures. The program will be open to health systems, group and solo practices, FQHCs, Indian health programs, and some critical access hospitals. The program offers a gradual shift to prospective payments over time, with enhanced payments and AAPM status in the later 2 tracks, which offer a number of benefits. The payments consist of 6 different types, which include an upfront infrastructure payment of $145,000 if you're joining in the first track and therefore new to value-based care. It also includes a shift to prospective primary care payments, which will be 50% prospective, 50% fee-for-service in track 2, and 100% prospective in track 3. Also included is an enhanced service payment seen here, which decreases as you go through the tracks from 15 down to 8 per member per month. The performance incentive payment is an upside-only payment based on performance of the required quality measures and is a maximum of 3% in track 1, up to 60% in track 3. So although the ESPs decrease across tracks, the PIPs increase quite substantially in tracks 2 and 3. There's also an e-consult code and co-management code, which help improve access to specialty care and are designed to encourage collaboration with other providers. You can see the graph here. This is a sample payment from Medicare showing the different revenue sources from the model. And you can see in track 3, the performance incentives really provide quite a substantial increase in revenue. All right. The next model is something that's near and dear to my heart, coming from the post-acute space. The Guiding and Improved Dementia Experience, or GUIDE model, is another new program, and that incentivizes a new approach to providing dementia care. Applications were due at the end of January, and the program will be an 8-year model running from July of this year until 2032. The program will focus on dementia care management and aims to improve the quality of life for those living with dementia and their caregivers. It offers comprehensive care management, caregiver support, and paid respite services. The program has a number of requirements, which include an interdisciplinary team consisting of a trained care navigator, as well as a clinician, either a physician, nurse practitioner, or PA, that has dementia proficiency. The program also requires a comprehensive care plan for patients and 24/7 access to a support line, as well as paid respite services, which is a huge benefit to caregivers. The CMS is really encouraging collaboration with other organizations. So if there's a requirement that your organization currently doesn't meet or can't provide, you're allowed to contract with third-party providers, such as for the 24/7 support line or the respite services. For patients to be eligible for the program, they must be community dwelling patients with dementia and must be enrolled in Medicare's Part A and B. So Medicare Advantage patients would not qualify for the program. They also cannot simultaneously be on hospice or a resident of long-term care. The payments for this model include an upfront infrastructure payment for safety net providers, as well as a monthly dementia care management payment. This DCMP is based on patient complexity, whether or not they have a caregiver, and how long they've been in the program, with the expectation that initial care planning and evaluation requires more care upfront, resulting in a higher initial payment with decreasing payments over time. These payments range from $390 for more complex patients initially, down to $65 per member per month. There's also performance-based adjustments, anywhere from -1% to an additional 6%. And CMS is including a health equity adjustment designed to offer more resources to providers serving those underserved communities. And this will be based on a health equity score. The required quality measurements for this program are listed here, and they're designed to measure and promote high quality care for patients with dementia. The applications for the guide model are currently under review. All right, the next model is the Innovation in Behavioral Health model. There isn't a whole lot of information yet released on this program, but it'll be a state-based voluntary model running for 8 years. The 8 states participating in the model have yet to be announced. The program is designed to deliver person-centered integrated care to Medicare and Medicaid populations with moderate to severe mental health conditions and/or substance use disorders. Payments for the program include a cooperative agreement consisting of up to $7.5 million per state, in addition to infrastructure funding. There's also an integration support payment of between $200 to $220 per member per month, and it also includes an upside-only performance-based payment, similar to the payments in the other programs we've talked about. Eligible participants will be community-based behavioral health organizations, which include community health centers, public and private practices, opioid treatment programs, as well as safety net providers. The notice of funding opportunity will be released this spring, with the program to start in the fall of 2024.
And I just want to mention here that CMS's definition of seasons follows the equinoxes and solstices, as far as I can tell. So it might not be what you think of as spring in your part of the world, but spring ends June 30th for them. So just keep that in mind. When you see spring or fall or summer on here, that's what we're talking about.
And now we'll hand it off to Pat to talk about the AHEAD model.
Right, thank you, Stephen. So similar to the IBH model, the AHEAD model is a multi-payer voluntary model running between 2025 and 2034 and will involve up to 8 states. These states have yet to be determined as applications are ongoing. The intent of this model is to really empower states to curb their cost of care growth while improving population health and decreasing disparities in health outcomes. With this in mind, it kind of builds off of total cost of care growth models that have been implemented in other states. So there are 3 main participants in this, with the state Medicaid agencies or entities with rate setting and budget authority being the main one who will be applying to this model. Once they apply and they're accepted by CMS, then these state agencies are the ones that have to recruit the other 2 participants in the model. So it would be the hospitals, which include general acute care hospitals, critical access hospitals, and then also the primary care provider participants. So these will be the primary care practices, can be federally qualified health centers and rural health care centers. And similar to the other payments that are received in other models, this one will also have an upfront cooperative agreement payment that will be given to these state agencies. and this will help the state agencies set up the infrastructure to ensure the success of this model. So this will include not only the recruitment costs of recruiting the hospitals and primary care providers, but also the cost required to really boost up the primary care infrastructure as well as behavioral health infrastructure. And then the other two payments are the hospital global budgets that will be provided to the hospital providers in this, and then also the enhanced primary care payments that will be given to the primary care participants. And so there's still a lot of unknowns with this. There will be more information coming out once all the applicants have been accepted and submitted. And with this, because of that, there are some restrictions about which states will be allowed to participate in this model, depending on your participation in other CMS models that we've already discussed. So if you have any specific questions, please feel free to drop in the Q&A and we'll get back to you on that. All right, and then Georgia will take us through the next model.
Yeah, absolutely. And just one more comment on that AHEAD model. Just keep in mind that these are the states that are applying first, and the first two cohorts have already applied. We should be hearing in May who those states are. And then there's room for one more cohort. So if you would really like your state to participate in this, you think this is a great idea, you can still nudge your state Medicaid agency to apply for this and get your state in by August. So there's kind of a rolling start date for when these programs will get going this next year. So the next model is called Transforming Maternal Health Model, TMA. It is a 10-year model. It's going to start on January 1st of next year. And again, this is another one that will have multiple states, 15 states or sub-state regions. So this could be like a metro area, but they are not decided yet. And in fact, the Notice of Funding Opportunity, or NOFO, is not even out yet, but they say it's forthcoming in the spring. So we should see that by the end of June. And applications will be submitted this summer. So this is all about improving maternal health care for Medicaid and CHIP patients. Not too many Medicare maternal health costs, I suppose, but so this is really a Medicaid-focused model. And it's in collaboration with, birthing centers, any sort of health center and hospital, where there are births. It is providing cooperative agreement funding of $17 million per each state. And then there's a couple years to kind of build up the infrastructure, but by the third year in the program, the state allocates some of that money to kind of distribute it out to those birthing centers. Let's call them birthing locations as infrastructure payments. In the next year, there would be upside only kind of incentive payments for cost and quality performance. And in the next year, they would transition to a fully value-based payment model, such as a risk-adjusted prospective payment with retrospective reconciliation. I know that's a mouthful, but it's really kind of saying we'll pay you upfront, we'll see how you do, and then we'll come back and either pay you more or reduce your payment kind of at the end of the year, depending on how you're doing on these quality measures and cost measures. So very exciting. Stay tuned for that one. Just wanted to put this on your radar that this is forthcoming. And then the last model we're going to talk about today, the last individual model, is the radiation oncology model. This one caught my eye quite a few years ago now. It is a mandatory model. It's a 5-year mandatory model that was supposed to start in 2021. Lots of things that were supposed to happen didn't happen because of COVID. But it is still TBD when exactly it's going to start, but something to be aware of because it is mandatory. And they have randomly selected these CBSAs. It's basically a large list of zip codes. And on our next slide, I'll show you a map of where those zip codes are so you can get a sense if maybe you're sitting in one of those zip codes today or not. But basically, it is looking at a host of different cancer types, and then a 90-day episode of care following diagnosis, and changes the way that providers, oncologists are paid when you're providing care in those conditions. So you get a 50% prospective payment, the other 50% is retrospective, and there's a professional and technical component and certain withholds that you can earn back based on quality and patient experience measures. So yeah, this is another one to definitely stay tuned to and take a look at the map and see if you might be in one of those areas. We just have kind of a little flag at the center of each of those zip codes. So something to be aware of. We don't have a time on that yet, but it is a planned model. So we've talked about a lot of different models today. This timeline summarizes kind of some key milestones for each of these models. So you'll see that MSSP is green, it's active, it's been active for 10 years, and it, as far as I know, will continue to be active for another 10 years. But every year, we could have stars on here every year because they do accept applications for new ACOs typically every year and allow you to add or remove participants in each ACO. The primary care flex model, again, those stars are aligned with MSSP. It's part of that application process this year and will start in 2025. ACO reach is just ongoing. Making care primary and guide model, those applications actually have already passed. And we're really just at the point now of applicants determining if they want to participate and sign off on those participation agreements, or waiting to hear back a determination on their application for the guide model. So you'll see the stars are kind of this maybe a tannish color on those last four models those last three models you see there, IBH, AHEAD, and TMA. And that's because those are the states that are currently applying for those models. So unless you're a state Medicaid agency on the call with us today, there's nothing that you need to do right now for those models. It's really just a matter of hanging tight and seeing if your state is participating, and then how you can take advantage of those models if your state is in. So with that, we'll go on to our third polling question. And just want to mention that you don't have to get the answers right to still get your CPE credit. So it's just a matter of answering the question and you'll get your CPE, don't worry.
Right, thank you, Georgia. So the third one is, which model will be open for applications from ACOs, providers, not the state agencies? And is it TMA, Medicare Shared Savings Program, AHEAD, or IBH? And while you're responding, quite a few of you have been asking, but if you would like a copy of today's slides, you can download them now from the console, and then we're also sending them out via email tomorrow, along with a recording of this webcast.
And we got lots of good questions about the MSSP that came in, I think, when I was chatting about that a few minutes ago, so I'll answer a couple of those. One of them is, how does CMS benchmark that the complexity of patients are the same in the benchmark and the testing periods? And one of the elements that they use in their calculation is the HCC risk score. So it's really just, it doesn't mean that that has to be the same in the benchmark and the program year. But if there is a change in complexity, that's going to be reflected in the calculation because it's a multiplier in that calculation. There is a cap on it, so you cannot increase risk scores by more than 3% over your benchmark. So getting back to that other question about gaming, it kind of puts a limit on anybody's ability to game that, although, that might be hard to do anyway. Okay, so we got another correct answer here on our poll, where the Medicare Shared Savings Program is what is open to applications from ACOs or providers and not the states. So it's really the states that are applying for TMA, AHEAD, and the IBH model right now. Okay, we'll keep going. So we're moving on to the last segment of our presentation. It's about strategic considerations and how to really be successful in these models. So you're not jumping into the deep end. And I think I've been to about 100 conferences where I saw slides where, you know, somebody has 1 foot on the dock and 1 foot in the boat, but it is a good metaphor because it does feel like that sometimes, where maybe you're doing some value-based work and other fee-for-service work, and it's hard to kind of reconcile those things. The transition time is challenging. That is how it is. But I think it is important to think about and evaluate any of these alternative payment models that you might be considering. So understand the model really well before you sign up for it. Understand the timing of the cash flow. One of the questions in the chat box was about sort of cash flow in the Medicare Shared Savings Program. And I would say that is a consideration, because there's your program year, and then if you earn shared savings, you're really not going to get that big check until 9 months after the end of each program year. So that can be a barrier for folks who maybe don't have money to invest to do the work of the ACO and then wait for the shared savings payment. That is kind of where all those aggregator companies come in. And that is why we're seeing things like PC Flex, where CMS is saying, hey, we'll give you some of that upfront incentive payment. We'll help you pay for some of the infrastructure of this so that you can get your foot, you know, on the boat. But understanding everything about it, understand the quality measures, understand what's required for your annual reporting processes. Is it a manual clinical data abstraction? Is it something you can do electronically through, you know, your IT vendor, that kind of thing? You definitely want to understand who's going to be participating in it. Who are your partners? Are you doing this alone, or do you have specialty care partners? Who are your primary care partners? Just understand, you know, kind of who's going in on it, and do you have good data about their historic performance? And you might not, but, you know, kind of knowing what you know and what you don't know is important. We work with a lot of organizations to just develop out a kind of pro forma, a model budget of, you know, what is this really going to look like for us? What's a best case? What's a worst case scenario? Being an accounting firm, we can't really say best case and worst case, but a good case and a bad case scenario. And what do we need operationally to make this work, and what's that going to cost? So understanding the potential cost and benefit, obviously very important here. Also just thinking about the broader landscape. We've had clients who, you know, have competitors in their market, and things are shifting, and this, you know, look at what our competitors are doing. We need to do something that kind of matches that or keeps up with it. So understanding that, and understanding how you, again, might partner with other folks in your area or maybe somewhere far away, but you can still work together. There are short-term and long-term priorities that are kind of typical. I wouldn't say that every ACO does it this way or does it the same way, but these are some of kind of the typical strategic considerations that we see with ACOs. And some of the nuts and bolts is really, you know, having a good data warehouse to ingest claims data, marry it up with some of your clinical data, and having those business intelligence tools and analytics capabilities, so that it becomes something meaningful about, you know, who do you want to target for interventions? What does our population look like compared to other ACOs or national or regional populations? You know, what issues do we really need to focus on here, you know, where we are? Having a strong chronic disease management program for that, you know, 10% of patients that make up 60% of the cost, the whales in the casino, really need to take care of those people. And then having, you know, a population health management program that includes annual wellness visits, and, you know, managing everybody, not just the ones that present with illnesses, but really taking care of everybody, keeping people healthy. I'm gonna keep going here. So we have our last polling question here, and then we'll have a few more slides. So I'll hand it over to Amy.
All right, thank you. So the last question is, where is your organization currently on the path to participating in a Medicare or Medicaid alternative payment model? And then while you're responding to that, I do want to let you know once you've completed all CPE requirements, you will be able to download a PDF of your certificate from the CPE progress window. A copy will be emailed within 2 weeks as well.
And there was a question in the chat about how are Medicare fee-for-service lives attributed? Is it based on certain billing codes? And this again is about the Medicare Shared Savings Program, but this is applicable in other models as well. So they look at the plurality of primary care billing, and plurality is just a fancy word for the most. So did they spend the most dollars at your primary care facilities versus outside of your ACO? And if it was more inside your ACO, then they are attributed to the ACO. So it isn't about hospital charges per se, it's about where they got their primary care. And yes, there is a list of certain billing codes. It's pretty stable. It's those kind of 99 codes, E&M codes, but they add to it, and certainly I'll get into this coming up, but they have health equity codes and population health billing codes and all those annual wellness and welcome to Medicare kind of visits that are going to get your patients attributed to you. Another way to get lives attributed to you, it's a little bit less used, is through a voluntary attribution where the patient can actually select you on, I think it's mymedicare.gov, where they can basically log in and then pick you as their primary care provider. And then no matter what, no matter where they go, it's gonna be your life. I'm so excited to see 39% of our responses say we participate already. So obviously this is an audience that's familiar to some degree with these models. Whether that was voluntary or mandatory, I'm glad that you're at least getting a foot on the boat. So excited about that, and I'm excited to follow up and talk more with those who say you're interested but want to learn more. You'll definitely hear from us. So maybe you heard this presentation today and you're thinking, well, that's all nice, Georgia, but I'm just not ready to do this, and we're not ready for alternative payment models at our facility. Totally understand. You don't necessarily have to jump into one of these, total cost of care or capitation kind of models. You can be doing things that help prepare your organization for future success. So certainly focusing in on your quality scores, your IT capabilities, as well as your HCC coding is going to help kind of lay the groundwork and the infrastructure so that if you decide you want to do MSSP next year, or one of these models becomes available in your state and you want to enroll, you're going to have some of that really kind of crucial infrastructure in place to be successful when you're ready for it. I will also add there is, population health and health equity billing codes. So you can do really good work that supports value-based care and get paid for it. And it's really exciting that Medicare values these things and wants to pay you to do them. So I know we're running out of time here, but just want to highlight that at the bottom of this slide, you'll see a whole list of different primary care kinds of services that a lot of folks don't often realize that they can provide and help those chronically ill patients. And you can bill Medicare for doing it if you meet certain specifications for each code. But these are good strategy, and you don't have to be in an ACO to do it. It can support you if you're in an ACO by helping those chronically ill patients and reducing admissions and readmissions, that kind of thing. But it really is maybe a good starting point for folks who aren't in value-based care yet. And brand new this year in the 2024 physician fee schedule, they've added some of these health equity services as well. So again, no copay on these. Any organization can use them. So take a look at that. If you haven't seen this already, there's a link to the MLN bulletin in there, and you can learn a bit about those as well. At the end of our deck here, we just got a bit of a summary of how we can help you. So I know we've talked a lot about kind of how complicated these different models are. It can feel very onerous. It can feel like a lot to take on. But I've seen a lot of folks be successful in these models. And you can be successful financially. It can be successful for your providers because they get to spend more time with those complex patients that need more attention, and not have everything so kind of time limited. And it can be successful for your organization's quality scores as well. So lots of good reasons to do this. And there's lots of ways we can help you. We're just really excited that there's so many new opportunities coming out in the coming years. So we would love to help you navigate those and take advantage of them. And at the end of our deck, we have our bios. I'm going to skip through those. I want to just tell everyone about an upcoming webcast about cybersecurity and mitigating your cyber threats. So be sure to check that out if you would like to join us again at the end of the month. And we have our upcoming healthcare conference. Okay, thank you. Thanks for joining us.
All right, thank you, Georgia, Stephen, and Pat, for a really great presentation today. And to our audience, here's a link to a survey for today's presentation. Your feedback is always appreciated. And again, thank you for joining us. Take care, everyone.